all kinds of joints that we have to consider. When we look at the less obvious, the cervicothoracic, we talk about posture. We know that we need an upright posture to be able to move our shoulder. We know that if we're in this kyphotic posture, it's difficult to raise our shoulder to core elevation. So really encouraging people to look at their posture enhances their shoulder motion for sure. Sternoclavicular joint, we know that that clavicle acts as a strut, just like a car. Brings it away from here. That notch here, the manubrium, we've got a disc there, we've got a capsule, we've got a closed pack position. I'm not too worried about all that kind of thing. I just want you to think about the anatomy and what we're dealing with there. Acromioclavicular joint, we know it's a convex-concave relationship. We've got ligaments all around it. It is relatively weak in terms of the capsule, okay? Again, I'm not too worried about the closed pack, the capsular pattern on all that. Scapulothoracic, we know that's going to go from T2 to T7. We should be roughly 5 to 6 centimeters from the spinous processes, okay, lateral. If you see somebody with this kind of posture, their scapula are going to be further away from those spinous processes. That's something that you can measure. Sometimes a PT will measure that to measure the level of protractedness of their posture, okay? We know that thoracic cage is we've got a convex, concave relationship with the scapula, but we know that it's really important that we've got to have stability here to use our shoulder like we want to. If that scapula is winging, upperly rotating too much, too protracted, things are not going to work right. Rhythm, we talked about this, right? 2 to 1 over the entire range. So 120 degrees of glenohumeral elevation to 60 degrees of scapulothoracic upward rotation. We're going to finally get this right, okay? Upward rotation of the scapula, roughly 60 degrees, added to the 120 degrees of glenohumeral motion equals 180, okay? Proximal stability for distal mobility. We've got to have a stable scapula, okay? If we don't, we're not going to be able to use our shoulder like we like. Glenohumeral joint, pretty simple. Humeral head, glenoid fossa, labrum around that outer ring. We've got ligaments that are all around it. What are the dynamic stabilizers? You guys know this already. What is that? Rotator cuff. Rotator cuff are the dynamic stabilizers. Their goal, their action is to keep the humeral head centered on the glenoid. No matter what we're doing, we don't want it popping out, okay? Humeral head is big, much bigger than the glenoid, okay? It's very small, concave surface, 1/3 to 1/4 the size of that humeral head. So how does it fit? How do we not dislocate every time we raise our arm up? The labrum helps deepen it a little bit, but the biggest thing is that rotator cuff because it keeps it centered. Think of a golf ball and a golf tee. That's our relationship there between the glenoid and the humeral head, okay? This original lecture was to a DPT program, so I'm not talking much about articular surfaces and all this type of thing. It's more valuable. So the labrum, is it a rim? Is it a fold? That's a lot of debate. And it's different in different areas, so don't worry about that too much. But our function of the labrum is stability. Again, making that glenoid a little deeper and to reduce compression. So we don't just jam this thing in there every time we do a push-up or something like that, okay? We need to be able to keep it centered. We need to be able to reduce the compression. Ligamentous structure, all around it. All around it. Not worried about it in terms of detail. C5 innervation. What does that mean, really? So the nerve root coming from C5 is what's innervating this capsule, okay? So if you have a problem with a C5 nerve root, could that manifest itself as shoulder pain? Yep, happens a lot. That's my whole purpose of putting this in here, is to talk about how you've got to screen the cervical spine when you're a PT, when you're dealing with the shoulder. So if you get somebody and the PT's done a really, really quick assessment, and all of a sudden you got them and they just talk about all this pain, but you can't see any problem with the shoulder or what have you, go back and look at the spine. That's when you're going to look at Sperling's test. You may want to do some traction to see if it helps alleviates. But that's a very real possibility in this whole scheme of things. Closed pack position. What does that mean again?
It's when it's the tightest fit.
When the joint is the tightest fit, when it's the most congruent, is abduction and external rotation. Okay? So we get the most contact there. Capsular pattern. What does that mean? When it starts to stiffen, this is the progression that you're likely going to see. You're going to first see limitation in external rotation. Then you would see limitation in abduction. And then you would see limitation in internal rotation. So, the biggest take-home message of this whole thing here, if you can get external rotation back on a stiff shoulder, everything else will fall into place. I've only had probably 2 or 3 shoulders in 30 years that I could rotate their shoulder into external rotation passively, and they didn't have all their other motion. And those were just freaky things. I don't even know what happened with those. Okay. That's the big take-home message here. Stretch that external rotation if you're getting a stiff shoulder. All right, there's dynamic stabilizers. Centering phenomenon, we talked about that. The way I teach shoulder is a little bit different than we just talked about spine. We talked about a flexion bias and an extension bias and a hypermobility and a hypermobility and all that kind of thing. It's a little bit different the way I teach this, because I think there's a couple different paths we have to go down. Rotator cuff disease, subacromial pathology, tendonitis, bursitis, impingement, that's one category. Okay, that's going to be below the acromion, underneath of it, something's happening. Not good. It can involve the tendons, it can involve the bursa, it could just impinge from bony structures. We'll talk about the scapula here in a minute. But something bad is happening underneath the acromion. Now, that can lead to a lot of other problems, right? We know that if we keep raising this arm up and we get that pinchy feeling, and we keep working it, we keep throwing, we keep doing overhead stuff, we keep painting, we keep doing stuff, we're going to start degrading that tissue underneath there. It starts rubbing on that cuff. And the more it rubs, the more it degenerates, the less it heals, the more problem we have of the tear. Okay? Motion restrictions, adhesive capsulitis, osteoarthritis, we treat these very differently, okay? As well as we do with instability. And then peripheral nerve injuries are just kind of out there. It's a whole separate category. So the most important thing from a PT standpoint is good diagnosis and differential, okay? As a PT, I've got to be, because a lot of times I'm going to get this referral that says shoulder pain. evaluate and treat. It doesn't say it could be any of these things, okay? But as the PT, I've got to determine, am I dealing with a subacromial pathology? Because I'm gonna treat that a whole lot different than I'm gonna treat this motion restriction problem or an instability problem. That's when we're gonna use all those special tests and all that other stuff that we talked about. I need you guys to understand that, but that's not your job. So the PT then is said, okay, we're dealing with impingement here. How are we gonna treat it? All right, so let's talk a little bit about that. There's other systemic stuff that can happen. Again, you can rule out radiculopathy. Cardiovascular problems will sometimes manifest themselves as shoulder pain. Pulmonary, respiratory issues, stomach, duodenal, and pancreatic cancer all can refer pain to the shoulder, as well as breast cancer, prostate cancer, diabetes, thyroid conditions, all of those. Somebody can come to you with shoulder pain and have something like this. It's very real. It can happen. But if we're talking about that subacromial pathology, the impingement stuff, it's the most common. There's a tremendous wide spectrum of severity. How many people in here have had a sore shoulder? Probably half of the class, more than half of the class, okay? And it's probably just some type of overuse, right? Whatever you were doing, you did too much. It is usually progressive. So when we see this occur, it will usually get better, but not altogether better, okay? You're usually predestined to have some of these types of things. And again, you're gonna see all these different, you'll see rotator cuff tendonitis, you will see bursitis listed, you'll see impingement, subacromial inflammation. They all really, they're not exactly the same thing, but we're gonna treat them the same way because we're gonna evaluate and treat that subacromial pathology. What's going on under that, okay? So just some quick stuff on what is impingement. Dr. Neer was this first guy to talk about this. He talked about it as an extra-articular lesion. There's a bunch of different classifications of different types of impingement. I think we talked a little bit about those things. Lots of different things can happen with this. Structural factors. You can have abnormalities. You can have an AC joint abnormality. You can have an acromial abnormality. You can have a humeral. Any of these things. These are bony problems. Can we change bone for the most part? No. So therefore the rehab is not what they need. They need somebody to go in here and straighten this bone out. Shave off some bone spur or extra shape to a acromion, which I will show you right here. If you're born with a type 3 acromion, right here, with that hook on the end of it, your cuff is going to catch that almost every time you go over your head. That is never going to change with no matter what we do in therapy. So what they do, they go in here with a scope and they shave that down. And they make sure that this is nice and smooth for motion to occur. This type 2 is a little more curved here. This can be a little more problem because this space becomes less. This space is greater. This is what we want, type 1. When this starts getting a little curved like this or this hook, these are problems. Problems that we can't do anything about for the most part. Okay? These are the folks that respond very well to relatively simple arthroscopic procedures that trim all that up and allow for things to move properly. So there's a lot of things that can contribute to this. If you have a weak cuff, if you're just inherently weak, that's going to mean that that ball doesn't sit on the socket very well. So when you go to put something up in the cupboard or wherever, that thing's going to ride upward and it's going to pinch. It'll pinch that cuff and the other tissue around that. If you've got scarring, if you have thrown baseball all your life and your cuff has been damaged due to overuse, it's going to be weaker. Okay? There's another thing that's, since I've done this, made out this lecture, is fatty infiltrate. If you got somebody who is morbidly obese and older, they will have more fatty infiltration in their rotator cuff complex. That don't work very well either. Fatty cuff is not good. It's gonna be in that weakness part, okay? There's a lot more studies talking about fatty infiltrate. Capsular hypermobility. So if we've got somebody who's just super loose and their joint goes every which way, that ball doesn't stay in there very well, okay? Not a lot of dynamic stability there. That's gonna be a problem. It's also a problem if they don't have enough mobility. Have you ever seen somebody that's really stiff, and you guys probably haven't, but if you see somebody that's really stiff in their shoulder and they try to move it, this is what happens. The whole thing moves. So that's not normal glenohumeral motion. So their scapula just goes right along with it. And that's gonna create impingement. So we gotta have somewhere in between these two. Scapular malposition. You guys have seen this. You've seen people with protracted scapula. You've seen the video we had with the wing scapula. None of those are good. Those don't work. Parascapular weakness. If you're weak in your scapula, you're gonna have a more unstable scapula. It comes right back around to this. And then we've talked about this before. If you are really tight and stiff in this cervicothoracic area up here, you're not gonna have good motion. So sometimes, there are times when I have just treated someone's thoracic spine and worked on their mobility, and their shoulder motion gets better. Okay, so all of these things are great rehab candidates. These are the people that you're gonna see, and we've gotta make a positive impact. You'll notice that this list is a whole lot longer than this one list that's not successful. We can help so many different shoulders. We just gotta know how to tease them out a little bit. So again, the way impingement occurs, you get some inflammation, it's usually reversible. This is somebody young. But because we do this and we do it repeatedly, it becomes more fibrotic, you get more chronic tendonitis, you know, maybe they've got some spurring developing and all that. This tends to be ages 25 to 50. And then beyond that, that's when you're gonna get more of the spurs, tendon rupture, progressive disability. That's kind of the progression that you're gonna see with that. So if we look at it from a phase standpoint in the rehab process, we've got this acute painful stage, phase one. You know, you've gone out and you have painted your house, and your shoulder is red hot. So what do we, as clinicians, what do we want to do? We want to diminish the pain and inflammation. How do we do that? Ice modality. What else?
Immobilization. Just keep it.
Mobilization. Is that going to
I said immobilization.
immobilization?
Yeah, keep it.
Okay. Gotta be careful. I think some rest is good, but I don't want to put somebody in a sling with this because that's gonna make them stiff. Anti-inflammatories. I'm always very careful about that because I'm not a pharmacist, I'm not a physician. But a lot of times I will say, if someone is not taking some type of anti-inflammatory, if it was my shoulder, I'd start taking some Advil or what have you, okay? Normalizing motion. If we got someone who's getting stuck, we need to unstick them, okay? You'll be surprised because you won't see a lot of people in this phase. They usually come to you a little bit later. They've had it for a month, 2 months, and they tend to hold their arm like this because it feels better. Guess what their arm's gonna present with? Stiff, stiff, okay? So we gotta start getting some motion back. Baseline dynamic stability, that means getting their cuff to fire, okay? We need that to work to keep that relationship, to keep things centered. And again, just common sense, telling them, hey, you gotta rest this for a little bit. You need to use some ice. You don't need to do what you were doing that got you here in the first place. If it hurts, don't do it. That's my favorite thing to say to people with shoulder pain. If it hurts, don't do it. Let me rephrase that. When I say shoulder pain, if I think they have this impingement stuff, if it hurts, don't do it. Because if this is the relationship, we've got tendons in here, bursa in here, and we keep ramming it up in here. That space then comes with fluid, swelling. We got even less space, and we just keep ramming it in there. It becomes this vicious cycle. Don't want that to keep happening. That's our job. We've got to teach them that. How many times do you hear people say no pain, no gain? That's the dumbest thing you could ever say to somebody with an inflamed shoulder. It doesn't work. I'll throw through the pain. I got to get loose, I'll throw through it. Not happening. Won't happen. Hopefully we get them to this intermediate phase where we're trying to get them to full and pain-free range of motion. We start working on strength, endurance, dynamic stability, and talking more about that correct posture that we've been working on so hard. Chronic phase, okay? This is when we're gonna get somebody back to whatever they're trying to do. So again, keys to successful treatment. Again, your PT or your doctor or whoever sent them there to you has got to be accurate with the diagnosis. Okay, and if you don't think they're accurate with the diagnosis, you need to voice that concern. Okay? Probably in a diplomatic way, but say, hey, I'm just not getting the treatment response that I would anticipate here. ID to treat all involved structures. So again, if I'm looking at someone's shoulder and I don't look at their spine and how it moves in the thoracic, I'm doing them a disservice. Because I may be able to mobilize this and get the motion that I need. So it's not just what's happening at the shoulder. Asymmetrical tightness, not gonna see nearly as much. But if you've got somebody who cannot elevate, they just can't get there. We're going to talk about the glides and stuff that we need to do. We'll come to that. Restore strength, that goes without saying. More times than not, they're going to be very weak in external rotation. So their cuff is going to be really weak. Abduction, external rotation are going to be the two that you need to work on the most. Early avoidance of activities, absolutely, that's common sense. Treating the cause and not the symptoms. Once we get the symptoms calmed down, if they go back to throwing a baseball and they've got that type 3 acromion, or even a type 2, it doesn't get better. It's only gonna get worse. That's when we gotta make sure that whoever they're seeing is addressing that, okay? Posterior impingement, we talked a little bit about that this spring. So that's when you get back here and you get all this external rotation, and you get pinching back here. So this is often seen in these overhead and throwing athletes, tennis players, volleyball players. It occurs in that late cocking phase of abduction, external rotation, and horizontal abduction. The supraspinatus and infraspinatus rubs on that posterior rim, results in fraying, and the key to this rehab is stabilize the scapula. Because what's happening is it's coming out too far. You get too much here, it's pinching back here. So if we can get better stabilization here, you'll see less of this. Traumatic impingement. You gotta fall into an outstretched arm. Shoulders often abducted, rotated. You just think about this humeral head that just gets slammed up into the glenoid. Okay, and again, hopefully that labrum helps to cushion it a little bit, but a bunch of impact like this is going to be really tender, okay? It can tear the cuff, the labrum, or even an avulsion fracture of that humeral head. You got to make sure that you know that this is what happened here, and there's not something else going on. But again, this should come from the physician, this should come from the PT. That's their job. Calcific tendonitis. Anybody heard of this before? So when a tendon gets stressed, just like everything else in our body, it starts to change its structure a little bit. Like if you pull on something on bone, if you stress bone, bone's gonna regrow, okay? Same thing can happen with a tendon. If you continue to put tensile load on a tendon, there is a chance that calcification will occur. I see it most in the bicep. Somebody that does a lot of lifting and carrying, and they've got this constant load on here, they will develop, oftentimes, calcific tendonitis. Right? The way that's treated, you'll see it through x-rays where you'll see some calcification there, treated like a compressive cuff. Iontophoresis with acetic acid. Acetic acid is what? Common name for that is vinegar. If you deliver vinegar to that tendon, that will help break up that calcification. Works really, really well. Secondary impingement. The underlying cause of this is just the instability. This is the young, super hyper flexible population. Usually these young overhead athletes, again, the key to this is stability and getting the athletes to comply, which is probably the hardest thing. Cuff failure, it's more a degenerative thing. The tear progresses from partial to full thickness. Majority of full thickness tears occur in those people over 50, and it's usually with something that breaks the camel's back, if you will. A fall, some type of twisting motion, whatever. And again, this occurs a lot in these sedentary individuals for a couple different reasons. Number one, their cuff is not strong, the tendon strength is not good. They've got bony bone spurs and so forth that create more of that inflammation. But the posture, when they get to this point, that gets pinched a lot more. Okay, so they do something very quick, it can tear. Causes of cuff failure, again, the majority is tissue degeneration above the age of 50, repeated microtrauma, weakening through disuse, hypovascularity, meaning it doesn't have enough blood flow anymore, repeated impingement, repeated steroid injections. So if you know somebody that's getting a steroid injection into their shoulder twice a year for every year, they're gonna end up with a torn cuff just about all the time. But major trauma you see is not that often. It doesn't really occur. It's usually a buildup of things. Again, the key to this is diagnosis. So again, that's on the physician and the PT. We want to make sure, from a non-operative standpoint, when they get sent to therapy, we address pain, we address motion, we make sure that their strength is balanced, they've got good scapular strength and stability, and if all else fails, and they can't, a lot of times we'll get some people with torn cuffs that are inoperable. The cuff tear is too wide, they can't repair it. We've got to be able to teach them compensatory techniques. We know that the bicep helps to elevate the shoulder, right? The deltoid can elevate the shoulder. So we've got to teach them those techniques if that's the case. That was like one of the toughest shoulders I ever had. Was a guy that was a full thickness tear. But he was really motivated. He really wanted to have surgery. Doctor wouldn't do it because it's going to fail. So I'm not going to do something I know is going to fail. So he sent him to therapy, and we worked on his bicep. We worked on his deltoid. And eventually he got to the point where he could do pretty much what he wanted. It wasn't exactly like he wanted, but he didn't have a cuff and he had a pretty functional shoulder. So I was really, really pleased. It took a long time though. We'll talk about compensatory techniques and stuff. Operative treatments, if you see these, I just put these on here because I want you to make sure you understand these abbreviations. An acromioplasty or arthroscopic subacromial decompression, you see that. distal clavicular excision, they will combine these two a lot of times. So they just lop off the end of the clavicle. A debridement is just a arthroscopic procedure that they can go in there and just clean up the joint a little bit. Or they can do a full repair. More times than not, it's arthroscopic at this point. There's very few open repairs that are still done. So acromioplasties or subacromial decompression. It is an operation, but there's nothing that is being repaired. We're just taking out bad stuff. Bone spurs, bursitis, whatever the case may be, additional inflammation. So the progression of the rehab can go a little quicker because we're not waiting for something to heal. Well, we're waiting for things to heal, but we're not waiting for anchors to secure themselves, okay? Nothing is repaired. It's only cleaned up. You know what? That's a good stopping point here. We'll start back tomorrow on this.